The Australian Shunt Registry is something that the Neurosurgical Society of Australia is working up to make available to consumers, to the industry and to neurosurgeons to try and bring greater quality and consistency to the treatment of hydrocephalus across Australia and New Zealand. The next slide. So the purpose of the Australian Shunt Registry is to improve patient safety and quality of care for patients with hydrocephalus and related conditions by monitoring and analysing hydrocephalus-related procedures performed throughout Australia. So that's not just shunt implantations, we're also going to look at endoscopic third ventriculostomy and some of the other treatments that are used for hydrocephalus as well, and all of that will be recorded in the database. So what we hope to develop, and what we've been working on over the last 2 years, is a national clinical quality registry to reduce the probability of adverse outcomes or problems associated with shunts primarily, but with hydrocephalus procedures in general. So the key objectives...
It just didn't come through because it's dark.
Okay. So the different objectives that we're trying to work on, I can probably change that if it will help, but I'll just read it out to those who can't see. Is the determination of the current indication, frequency and outcomes of hydrocephalus-related procedures. So what we want to work out is across Australia and New Zealand, for people with hydrocephalus, who's getting a shunt, who's getting an endoscopic third ventriculostomy, why more people in one state might be getting more of one procedure than the other, and try and bring some consistency and explanation across Australia and New Zealand. We want to work out why some shunts live longer than other shunts, so we want to get an idea of shunt longevity and device failure. So is there a shunt out there that's better than any others? So far there doesn't appear to be. And then what we want to do is benchmark and compare one shunt with the other, and also the institutions and also the surgeons. We want to try and identify any component that might have an unexpectedly high failure rate. So really, at the moment, I don't really know what happens in Melbourne, and the guys in Melbourne wouldn't know what happens in Perth. And by pulling our data together, we want to try and get an idea, is if something comes onto the market, we all think it's going to be better, is it better or is it not? And we want to benchmark out and compare one against the other. We want to work out the quality of care by benchmarking individual surgeons and units. So the idea behind that is that, for example, say I work in a unit with 6 neurosurgeons at the Children's Hospital at Westmead and at Westmead Hospital. If, for example, one person has a shunt infection rate that's 1/3 of everyone else's, we want to start doing what they're doing. And we want to use this to try and get the best practice available out there. So what we hope to do is gather unit data from all surgeons and all units across Australia and benchmark it, work out what the average is, who's better, who's worse, and try and get everyone as good as possible and learn from each other. If a new product comes out and there's a risk associated with it, we'd like to be able to detect that early. That's something that's come out of one of the other registries that I'll talk on soon. It's helpful for research and also for patient and shunt component identification. So for example, if you've been treated at Westmead Children's Hospital for 15 years and suddenly you move to Perth, it's very difficult for all of the data from all of the previous operations to go with you. You might get a couple of discharge summaries or something like that. But often if you're trying to look back 15 years, it's hard to work out exactly what's what. So, every now and again I'm asked to see a patient who had a shunt implanted at the old Children's Hospital at Camperdown. It's almost impossible to get those records within about 3 months because they're archived, they're not all digitally stored and things like that. So we're hoping that going forward this would be a great repository for that sort of information. So what's the data that we're going to collect? So again, I must apologise, I've made this colour wrong, but it'll come up on the next slide. So we're going to collect the patient identification, and that's been one of the sticking points of getting all of the ethics approval done. So we'll record the patient's name, date of birth, the medical record number, and their most recent contact information. We'll record the institution where the shunt is implanted, so which hospital it's put in, the surgeon that does the operative procedure, all of the details about the operative procedure, so the start time, the finish time, what the indication was, what the purpose of the operation was, is it an endoscopic third ventriculostomy, is it a shunt implantation, is it a shunt revision, what hardware was put in, what was found to be the problem with what was in there, and then all the outcomes associated with it. And we'll also record the shunt system components as well. So this is the slide that is the data collection form that we've worked up. So this is what we're actually going to record. So, it'll have the surname, the Christian name, the postcode, the date of birth, the sex, and the hospital medical record number. That may change if we end up with an Australia-wide medical identification number, which is one of the things about the new health record. The clinical diagnosis, so is it congenital hydrocephalus, say for example aqueduct stenosis or associated with a Chiari malformation, or is it acquired? So for example, if there was meningitis early after birth, or if the child was premature and there was an intraventricular hemorrhage, so what was the cause of the hydrocephalus? More details about that. Is it tumour related or not? Is it related to trauma? Is it pseudotumor cerebri or benign intracranial hypertension is another name that we use for that. Is it normal pressure hydrocephalus, a form of hydrocephalus that often affects older people? And all the operation details, so the date of the surgery, the start time, the finish time, who was actually doing the operative procedure, was it the registrar, was it the consultant, were there several people involved? What was the operation? Was it a shunt implantation, a revision or removal? Was it externalised because it was infected? Is an external ventricular drain used? Is a subtemporal decompression performed? An endoscopic third ventriculostomy or a choroid plexectomy? So it's not just a shunt registry only. And then all the details about the shunt. Where is the catheter? Is it in the right ventricle, the left ventricle, the fourth ventricle? What direction was it put in? Frontal, parietal, occipital? Is it into a tumour cyst, for example? Is it a lumbar shunt, a subdural shunt, or a cistern-magna shunt? The distal catheters go into your tummy, into your heart, into your chest, or is it externalised? What sort of valve is it? Is it a programmable valve, a non-programmable valve? Does it have an integrated reservoir? Is there an anti-siphon device as part of it? Then the manufacturer's details, the opening pressure, if it's a programmable one, whether there's a separate reservoir or not. And then, something that we've all been interested in lately was an antibiotic impregnated catheter used or not? Because again, we think that might be one way of reducing shunt infection. And then for revisions, what was the problem? Was it a blockage? Was it under drainage? Was it over drainage? Was the catheter in the brain blocked? The catheter in the tummy blocked? Was the valve playing up? Was it over draining? Was it infected? Was it a malpositioning problem? Was it fractured or disconnected? And then there's a field here where you can put in any comments. And the second page of it is all the details about the actual shunt system. So what company shunt is it? Is it a Medtronic valve? Is it a Strata valve? Is it a Sophie valve? The proximal catheter, is it a Bactocil catheter or a Johnson & Johnson catheter? What sort of valve is it? The distal catheter, what sort of catheter is it going into the heart or the tummy? Is there an anti-siphoning device? Are there any other components in there? I mean, as some of you may know, there are now programmable anti-siphon devices and all different sort of combinations are coming out. And then when you open the boxes of that stuff during the operation, there's always labels that come with it that have all of the unique identifiers on it. It's sort of like an aircraft part almost, so they can track each individual component if that data is recorded. So we stick the sticker on it and that can all get uploaded. And then we're going to get the surgeon who fills this out at the time to send it through to the Shunt Registry, which will be housed in our office, which is in Melbourne. Right, the next slide. So this is how we thought it would work best. So again, this isn't compulsory. You can opt out if you don't want your data collected and if you don't want it included in the registry. So at the time of the operation, the idea is that in every operating theatre where shunts are done, there'll be a stack of these forms with envelopes that can be sent back. The surgeon will complete the data collection at the time, they'll send it to the Shunt Registry, and then the Shunt Registry will contact the patient or the family member with a letter that explains what it's all about, similar to what I'm talking to you about today. And if you decide you don't want to be part of it, all of that data is going to be destroyed immediately and it won't even be recorded. If you want to continue, then it'll get entered into the Australian Shunt Registry. And over time, and we think every 6 months once we get it going, there'll be stakeholder reports that will come out on a website and to associations like this. We will be auditing to to make sure that it's complete and accurate. So the idea is that we will employ someone to go to the different hospitals. So say, for example, if it turns out that Westmead Children's Hospital has a 0% infection rate, we want to make sure that people aren't just chucking in all the ones that are infected. So, there has to be an audit and things like that to make sure that the data is collected is accurate and it's real. So we're going to create monthly reports that will feed back to the surgeons in the institutions. So, month by month we'll get an idea of how we're going. So, for example, the Children's Hospital at Westmead, we do about 3 shunt-related procedures a week. So, we would get useful information over a month. But for other centres that are doing fewer, then it might not be necessary to do it every month. We'll need to collect the missing records, so we'll need to do medical record audits, and like all of you, surgeons are pretty hopeless at filling out forms, and occasionally we'll miss a box and someone will open the ring and say, where's the spare, what sort of shunt was it, that sort of stuff. Next slide. So this will be what you guys will all get as patients and family members of people with shunts. You'll get a letter from us explaining what the Shunt Registry is all about, and you'll have an option to call, email, or send a letter back. And if you decide to opt out, we're going to destroy the record and no copy will be kept. And if you don't opt out, it will be included in the Shunt Registry, and that will be an ongoing thing, so that data will be sitting there forever. So if you have a shunt implanted in 2016 and you stay well until 2025, but then turn up at the Royal Perth Hospital, they'll be able to access the actual information through a web-based portal of what was done at Westmead 10 years ago. Next slide. So one of the key sticking points with all of this is going to be protecting your privacy as much as anything else, and that's been one of the things that we wanted to be absolutely certain we have correct. So the only people that will be able to access the registry is the Neurosurgical Society, so the neurosurgeons involved in treatment. And not every neurosurgeon can just troll through the database and see it. All has to go through the Shunt Registry Committee, and that has representatives from most hospitals and certainly every state. Access would be provided for management of the database, so there'll be a data manager who has to be able to enter the data and retrieve it. We want to analyse the data, obviously, so the idea is that there will be regular reports coming out, shunt revision rates, shunt infection rates. Certainly, if there is a shunt component that's identified as being problematic, to make that information available to people who need it. And then also an important part of this will be as a research tool. But again, the research would have to be approved by the Shunt Registry Committee and the Neurosurgical Society. So, for example, a company who wanted to compare data that they might have from a study they've done against our data, they couldn't do that unless they applied. So the idea is not that we're going to necessarily make this as a clinical trial thing, but if you want to compare one with another, this might be a good way of doing that. Next slide. So one of the key things was getting the ethics, the privacy and the governance right. So what we had to do at the end of the day, and which has been one of the time-consuming parts of it, is that we needed an institutional ethics committee approval, that's what this stands for each hospital. And that's time-consuming because they've all got slightly different ethics approvals, and you submit what turned out to be several hundred pages of documentation. It takes them a while to read it, they get back, they want to make some changes, you have to resubmit, and that has taken longer than we would have thought. And we had to make sure that all of what we were doing was compliant with the relevant privacy legislation, and the National Statement on Ethical Conduct in Human Research, and the Australian Responsible Code of Research. So it's compliant with all those things, and getting that right, and having solicitors look at the documentation and stuff like that. So the reports that we will provide regularly will be an annual report that will go up on the website and also be made available to anyone who wants it. So that'll look at revision and infection rates across the board, what the clinical practice is, where endoscopic third ventriculostomy is being done, where a shunt's being implanted, what devices are being used, are they mainly ventriculoperitoneal shunts, ventriculopleural shunts, and then we'll provide general reports that will be updated on the website and everyone will have access to them. Then there'll be confidential reports that will go back to institutions and individual surgeons so that we can compare our data with each other. So, you know, for example, I'm the head of neurosurgery at Westmead. I'll get the Westmead data compared to every other hospital that's contributing to it. And if, for example, you know, we have a lower infection rate, then we can feed back to other units what we're doing that might be better. Similarly, if we have higher rates, then we'll go to the other units and say, what are you guys doing that we're not? Why is our infection rate higher? And because we'll have all of that other information there, we can kind of adjust it for risk. So for example, if you're working in a children's hospital where there are lots of premature babies coming through with high intraventricular hemorrhage rates and infections from meningitis and things like that, you know, those shunts are more likely to get infected, for example, than say a shunt that's implanted in someone with sterile CSF in the setting of normal pressure hydrocephalus. So it'll let us adjust for risk a little bit. Also, for each individual unit, we'll get the identified data for all the surgeons. So, you know, I might be surgeon 1 in the 6 surgeons in our unit, and my infection rate might be better than all the other guys. And I'll say, look guys, I'm doing this, I'm using this kind of implant, I'm using Bactisil catheters, maybe you guys should look at that. Or, you know, my infection rate might be worse, then I'll look at the other guys and say, well, what are you doing? Are you using antibiotics prophylactically? You know, what's the difference and why? And it'll help us improve the practice for all neurosurgeons implanting shunts across Australia. That's the idea, is that we try and get everyone as good as possible. So, how's it worked so far? So in 2013, thanks to Brian Aller's efforts and the Society's efforts, and also all of your efforts in writing to your local members to encourage them to support this, we got $165,000 from the Commonwealth Department to develop the registry. But that was $165,000 and you've got to have spent it by the 30th of June, which is how governments tend to work. So next slide. So what we did was we looked around at what databases are out there, which are the ones that are working well, who's running them, and which are the effective ones, because there's no point, you know, reinventing the wheel. And the group that had the most productive database management was the one at Monash University. So we met with them, and ultimately they've developed the portal and the hosting mechanism for the Shunt Registry database. That's all completed, and it's basically ready to have data entered. Just last month, or 2 months ago now, finally the ethics approval process was completed just at one of our hospitals. So we pushed hard at the Sydney Children's Hospital Network, which is where I work as part of Westmead Hospital, also Randwick Children's Hospital is part of that as well. So after many revisions and going back and correcting the things that they want to change and proving that we were compliant with privacy and all of that sort of stuff, we got approval from the network, and we've now got site-specific approval, and we can start entering the data as of pretty much next week at Westmead, and the similar thing we hope will happen at Randwick pretty soon after. So that part's happened at one of the hospitals. The registry database is basically ready to go. Next slide. So we thought it would just be too difficult to send it to every neurosurgeon in every hospital in Australia and have any idea of how compliant they are and things like that. So what we thought would work best is that we would focus to start with on the places where most shunts are implanted, and also the places where the neurosurgeons are most likely to be interested in hydrocephalus. So for most paediatric neurosurgeons, hydrocephalus and shunts are a big part of what they do. For a lot of adult neurosurgeons, it's a relatively small part of what they do. So what we thought we'd do to start with is try and prove that it works in the surgeons that are most interested in the hospitals that have the greatest number of hydrocephalus patients. So in Sydney, it'll happen at the Sydney Children's Hospital Network and at Randwick, and that's basically going to start next week. In Melbourne, it'll start at the Royal Children's Hospital. Dr. Alison Ray, who's currently the treasurer of the Neurosurgery Society. She's the lead neurosurgeon at that hospital. She'll be presenting at the Melbourne meeting, and we'll go through a lot of this similar stuff in the Melbourne team. In Queensland, it'll be at the Lady Salanto Children's Hospital, the new children's hospital that's just opened there. In South Australia, at the Women Children's Hospital. In Perth, at the new children's hospital. And once we get it up and going, so we hope probably 12 months after we start, we'll then roll it out to the adult hospitals, probably the public hospitals to start with, and then hopefully to all the hospitals across the state. So usually once you get that going, it kind of snowballs. So really the first couple of hospitals are the hardest ones to get started. Once they're started and people can see the data, so we'll present it at meetings and things like that. You know, we're all curious as surgeons. We want to always be the best. We're competitive by nature, and we want the best outcomes for our patients as well. So, you know, if I can press a button and say to all of the neurosurgeons in the room, the database tells me that I've done 230 shunt revisions over the last 18 months, and my infection rate is 1.5% or whatever it might be, everyone else will want that same kind of information. So the long-term goal is to go, so can you just go back? So the long-term goal, what we're hoping is that all neurosurgeons and all shunts are included in the database. That probably won't ever happen because some people won't want their data collected, but that's the goal. So the Neurosurgery Society is keen to work with all of those groups that want to partner in this process. So what we got from the federal government was the seed funds to establish the database, but what we need is to then fund someone to enter the data, to maintain the database, and also to do the auditing. So, you know, we need someone to go out to Hospital X and say, that's great, your shunt infection rate is 0 and you haven't ever had to revise any of the 300 shunts you've implanted. Why is that so? Are there a whole lot of cases that aren't getting collected? And that's time consuming, and it takes someone who has a relatively good knowledge of hydrocephalus to do those sorts of audits. So what we need to do is we need to raise the funds to implement it and then to expand it and spread it out. Next. So why do we need more funding? Well, for the data input, for the audit and the quality assurance, to make the reports that will feed back to everyone, to expand the shunt registry across all sites, and then to maintain the shunt registry to, revisit the registry, to maintain the web portal, all of that sort of stuff. I mean, at the moment it's paper-based, but I think realistically within 2 or 3 years it'll all be web-based and we'll be doing it off our smartphones through an app or something like that. So what are the potential funding sources? Where are we looking to try and get the funds from? Ideally, we think it's an important enough issue that the federal and state government should fund it. I mean, people die from hydrocephalus. The problems associated with shunt revision can be really significant. If you get ventriculitis from an infection in your shunt, that can have devastating consequences. If you're having a hemorrhage because you're getting a lot of revisions, that can cause stroke. So the consequences of shunt-related problems are significant, and personally I think it is a significant enough issue that the federal and state governments really should take ownership for it and fund it. The other places we're looking at for industry support, so the people who make the shunts that we implant, Medtronic has given us a grant of, I believe, $20,000 to fund the next step of it. Ideally, I think it would be best if it was a government thing. The problem with having industry supported is that can change from year to year, and as the fortunes go up and down, they might not wish to continue to support it. Similarly, if one company found that they had a very high failure rate as a result of the database, they might decide that database is not such a great idea.
And also, you might have the myth of this is an industry thing. Is it independent?
Exactly. We're concerned about too. Is there a conflict of interest in how the data is going to be presented? Obviously, we're looking at community support. There's been some individuals who have donated, some associations that have raised money. The Surf Lifesaving is involved, and we're extremely grateful for that. And also individual donations. Yeah. So, what other registries are out there? What else is going on? So, there are 2 very big federally funded, so paid for by the government registries. One is the joint replacement registry. So if you have a hip replacement or a knee replacement, all of that data is collected in Adelaide, and those reports are provided regularly to the orthopaedic surgeon. So a friend of mine is a hip guy, and he was showing me, he can type in his code and he can find out, over the last 2 years how many right ones he did, how many left ones he did, what was his revision rate, what gear he used, and all that sort of stuff. And that's been very successful. So a couple of years ago they found that one of the components of one of the joints was failing at a much higher rate, and that was first identified through the joint registry, and then that was withdrawn. The other one is the breast implant registry. So there are many breast implants that are put in for important reasons like reconstruction after breast cancer, but there's also a lot of cosmetic ones, and there was all of that discussion about 3 years ago with silicon leakage and faulty implants. So the government funded the breast implant registry. My own view is that hydrocephalus and shunt-related problems are equally, if not more important than that, and they really should get on board with this as well. There are a couple of others that are funded by different sorts of societies. So the vascular surgeons have a great audit/registry, again, that they've developed with some government funding that they're maintaining on their own, that looks at things like abdominal aortic aneurysm repairs and the grafts they use for that and those sorts of things. The Australian Kidney Society has a kidney transplant registry where they keep a lot of very high-end data, and there's also one for burns as well. So there are others out there, and I think in terms of the potential impact, I think a shunt registry is really important. So the most effective one out there at the moment is the UK Shunt Registry. So I just thought I'd give you a little bit of information of what they've got from there. So by 2009, they had 33,000 procedures inputted in there. So that's a huge amount of data that they got straight away. And what they could then do is go back and look through all of that and kind of sort the data and work out, what's good, what's not so good. So over the last 6 or 7 years, there's been a big push to use antibiotic-impregnated catheters, and we all thought that would dramatically lower infections. In the studies that have come out, it does dramatically lower it, but if you look at the Shunt Registry database, it's probably not as important as was suggested by the industry-funded studies. So yes, it helps, but it's not as significant as you might get from reading the brochure from the folks that make Bactiseal or one of the other catheters. They also found, by looking through their data, that experience plays a role. So if a senior surgeon is doing the shunt revision, the revision rate is lower than trainees. That would be intuitively what you'd expect. One of the other things that was very interesting was that if you had your procedure done during daytime, the revision rate is less than at night. What might be the reason for that? Well, it might be that sicker patients are getting operated at night, or it might be related to surgeon fatigue. You'd have to go back and reanalyse that. Some general things that came out looking at their data was that 80% of shunts on average will fail over a 12-year period, so they're not lasting forever. And that all of the different shunts out there, and there are lots of them, I'm sure almost everyone who's got a shunt would have a slightly different one from the person sitting next to them. None has been proven to be better than any others, despite what the companies tell you. So again, this came from looking at several thousand shunt revisions from the UK database. It's looking at, is there a difference between adults with shunts versus kids with shunts? And to be honest, there's not a huge amount of difference. There's a slightly higher rate of shunt revision for infection in children than there is in adults, which is this part of the pie chart here. But all of the others are pretty similar, which I thought was quite interesting. And I think that reflects the fact that, in the very young children, they're much more prone to getting infections, especially if they've started out with a hemorrhage or if they've started out with meningitis. So what are the challenges that we see going forward from this? And there are several. So first is getting the surgeons involved to fill out the form. We've tried to identify leaders in each of the hospitals who will promote it and get everyone else involved. So we've tried to pick people in each centre who think that this is important and get them on the committee and get them involved. I think it will be a little bit more of a challenge, say, to spread it out to, say, the private hospitals where there might be only a couple of shunt procedures done each year. But anyway, the goal is, at the end of the day, we'll try and capture everything. Getting the data set complete is always a challenge. Getting the form filled out completely so that every item is in there. The audit and quality assurance thing is going to be extremely important so that we make sure that we're capturing all of the data from each unit, making sure that it's not been sifted so that one unit looks better than the other just by selecting the cases that do well. The ongoing funding is an issue, and then again the community support is really important. At the end of the day, we want patients with hydrocephalus to do better than they do the generation before, and that's what the database is really all about. And I'd be happy to take any questions.
So with your, what sort of costs are sort of associated with the registry? What are you looking at money-wise to fund it?
We think that the ongoing cost will be in the order of about $50,000 to $60,000 per year, roughly.
Yeah.
To start with, a lot of that will be selling the product, if you like, getting it out there, getting people involved, and then increasingly it will be audit and quality assurance, and then coming up with a report. So, I think we've recently relocated our NSA office. We're in the process of doing that, so we can actually have physical space for the data manager and the quality assurance person to live in our office, if you like, and we're going to employ that person beginning in February. And we figure it'll cost roughly $50,000 to $60,000 per year to do the data entry and all of the other stuff I mentioned.
Some statistics are going to be quite difficult to improve on. Like, for instance, you said like the experienced surgeon is going to be more successful than the trainee or registrar. But unless the registrar has a go, he doesn't get experience.
And every senior neurosurgeon that you see was once a trainee. And it's very important that the next generation of people that I'm training now are better than me. And this is one way of kind of storing that data so that we can benchmark against each other and get the new trainees to adopt best practice, make sure they're doing as well as they possibly can.
So how can we, as an association, support you?
Well, a couple of ways. I think very importantly would be to write to your local members, to the federal health minister, to the local health ministers and say, you guys fund a breast implant database. No one's died from a problem with their breast implant, but people die from hydrocephalus every year. And this is one way that we hope that we can improve the quality of treatment provided to patients with hydrocephalus, which at the end of the day is a life-threatening and disabling illness. So I think highlighting it to the government is extraordinarily effective. So if you could write to your local members, write to the federal minister, say the NSA wants to get this funded, it's up and running, please support it. It's amazing how much that helps.
And I gather that the registry is tax deductible?
Yes.
Good. So
Yeah, so the NSA is a not-for-profit society. To be honest, it barely breaks even every year, to be honest. And it's a completely tax-deductible research charity.
So, looking pessimistically, if you don't get the funding, what happens?
We're determined to make it work. So we'll get it by hook or by crook, we'll get it. So, I would prefer that it's funded by the government because I think that's the way of minimising any conflict of interest. If the worst comes to the worst, then we'll go to the shunt manufacturers and say, look, you guys need to fund this for all of these reasons, or we'll hold cake stalls or whatever. But at the end of the day, I think if it was funded in the same way as the joint registry and the breast implant registry, that's the best way of, keeping it away from any kind of conflict of interest, that there's no perception that it can be filled by any one company or any one, external influence. So we're lobbying government. I mean, we're fortunate. Brian Outler, who's a neurosurgeon with a real interest in hydrocephalus, is the AMA president at the moment. So he's been working behind the scenes to try and get some ongoing funding. But what we want is sort of a continuing funding stream so that we don't have to go out every year and say we need money again to pay for next year.
like I know that the funding environment at the moment with the government is very tight. Like there's been a lot of cuts.
Yeah.
Have you guys thought about like going for a grant so you can have like a proof of concept trial and start generating some good data and then go, look, this is going to save you, because of this data, we're going to save X thousands of dollars because now we've cut the infection rate?
Yeah, no, that's exactly what we're intending to do.
Yeah.
So we'll use the data to produce reports that prove the worth of the database.
Yeah.
And we've sort of got the funding in place for the first year anyway. It's just going to be a matter of then getting the reports out and getting the data in there.
Just a comment, like, because I did a lot of communication with the NSA. We should try and work together to increase community engagement. Like, you know, have something on your website about the Shunt Registry.
Yeah.
Like, you know, I'm based in Melbourne, so I was going to try and get down and see Stacey and.
Yeah. Now, we're very keen to engage with stakeholders in the community because at the end of the day, it's to improve the treatment of hydrocephalus for everyone. So, you know, this will all be on the database, absolutely. It's in the recent newsletter and all that sort of stuff. So,
this is like also like we're trying to get in touch with other patient organisations that we're aware of in Australia that we can all work together with.
Yeah.
So hopefully, you know, I know that in one of our meetings, we approved the donation to the registry. Been trying to lock down some bank account details, but
right. Okay, we'll get Stacey to get into it. Yeah, I mean, we're grateful for all of that support, but at the end of the day, the goal would be to get it funded by the government in perpetuity, like they have with the other databases.
Yeah, well, that'd be the best because it's going to save the government money.
Like, at the end of the day,
if we have less shunt surgery, it costs them less.
Absolutely.
Is it possible to get retrospective data? If you had someone on board, could they go back and get records for the last year or two?
Theoretically, that would be possible, but a lot of it is sort of captured at the time. So you could go back and get retrospective data, yes, but the best data is usually that's prospectively collected. Right. It's more likely to be robust and completed at the time. It's when you go back and do chart reviews, which we all do when we're doing sort of clinical research, it's often quite difficult to get some of that very specific data out. Like, what exactly did the surgeon find when they revised the shunt? That's not necessarily written down specifically.
Right.
You might say read an operation report that says ventricular catheter, Rickham reservoir and valve were closed. And it might be that only one component of that was malfunctioning, but for some other reason the surgeon decided to change the whole lot. For example, the connecting tubing was cracked or something like that. And that data you really need to record at the time. So you might not be able to tell from looking at an old operation note whether it was the catheter or the valve that was the problem. You just see what was revised.
My question was, when you talked about the patients actually saying they didn't want the information on the registry, did you consider not having their patient's details but still have the information recorded? Because that seems to me like a big loss of the information, whereas your issue was around privacy, which is about the person's details.
Yeah, the problem with that is that you could theoretically then go back and work out who the patient was, because the detail is so specific, the time of the operation, the day, all that sort of
serial number of the shunt, everything.
But it's those things, and I just wonder if people are going to later regret having had that information destroyed.
I mean, at the forefront of all of this was respecting people's privacy and things like that. So, that's quite a topical issue in all of the sort of electronic medical record things out there. So at the end of the day, there have to be an opt-out.
Yeah, maybe recording the opt-out rates. So
we'll definitely record the opt-out rates for sure. We'll definitely record the rate of opting out. But if someone says to us, I do not want you to collect any of my data, we're not going to collect it.
Yeah, I can see that beforehand.
And like
in a way, that's where we come in, to at least to encourage those members to reveal their information.
Yeah, sell the reason why it's a good idea.
And the internet, and certainly our internet, our website should be pushing the revealing of information for the betterment of everybody.
Yeah. So we thought that we would fill the form out so that, you know, that step's there. So, you know, for example, if you come in drowsy because you're shunt sport and acutely unwell, you know, we're not going to say, do you want to
Rip the form in your face and go sign
we're going to
out.
collect the data. And then if afterwards they come back and say, no, then we'll just destroy it. But the idea is that we try and at least get the data completed during the surgical procedure, because that's when the data's
Well,
most accurate.
and it'd also be the highest completion rate.
Exactly. So the further you get away from the point of care and the time of care, the less likely it is to get completed.
Yeah.
That's for sure.
Mike, with the, it sounds like you're thinking about a full-time staff member that would manage all this. Would an alternative model be for volunteers, you know, location-based that take part of the role and the audits are done centrally?
I mean, we think to start with at least it won't be a full-time person, so that'll be someone who'll be doing other things as well.
Right.
The problem is that it's actually relatively sophisticated, and also there's the privacy thing as well. So, you know, the person who's entering data will have, you know, a confidentiality agreement they have to sign.
Right.
And if you end up with a lot of people doing it, it's harder to keep it confidential, and that's been very much at the forefront of what we've tried to do.
So I have a little bit of an issue with this because
Yeah.
we can't even get a discharge report that makes any sense. They're constantly wrong. I don't
Yeah.
think we've had one that's been right in 23 years.
No, I agree with you, and that's the whole problem, is that that discharge summary is usually not written by the surgeon.
So when would the surgeon have time? That's my issue because
Given the operations.
really?
Yeah, I mean, you know, that's, at the end of every operation, I handwrite exactly what I did during that procedure. I don't move the room until that's done. This would be something that would be sitting next to the operation report that I just tick, 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 and the nurses would stick the sticker on and would stick it in an envelope and it's done. So, you know, I agree with you. I get discharge summaries and read it and think, and send it back and say, in turn, you've got to fill this out correctly.
We're still not 100% sure what setting he's on because the doctor had a different record to what we were told and what the discharge summary was, so we just...
Yeah, so that's the idea, is that if it's written down at the time, you know, you could always go back and get that data.
The other thing I think is that hydrocephalus isn't trendy, unfortunately. It's not known.
No,
And even my friends still go, what was that he has? Because it's not known. And until you get someone out there that's famous or is willing to step up and make it a trend condition, companies aren't going to jump on it. They want to see it in the media.
Yeah, I think one of the, I agree, it doesn't affect a huge number of people and it's not super trendy. However, it's extremely expensive. So if you get a shunt infection, you're probably going to spend close to 3 weeks in the hospital. You're probably going to have the entire shunt pulled out, a period with an external ventricular drain in, and a new shunt put back in. So, you know, that's a 30-day hospital admission, and the government realises that, you know, hydrocephalus is not common, but it's expensive. So although they want, you know, community pressure, and you guys can do that by writing to your members, they also know that the consequences of poor hydrocephalus treatment are extreme. It's expensive and it's potentially devastating for the individual. So I think they're the sort of real pushes for it. So it's not like, you know, a breast implant registry where it's very kind of common and you get people to step up. But I think when they look at what it actually costs them to treat shunt problems, you know, the average shunt revision without a complication at our hospital costs $12,000. That's someone who's in hospital for 2 days.
And Brian showed us some data that he'd done from his study of the cost of operations, and like, you know, and that was some of the stuff we used in the letter writing that we did for the initial funding. I mean, like, you know, like it was $12,000 to $20,000 per operation.
Yeah.
And if you got a shunt infection, like there were some outliers that were up to $500,000 a
Yeah.
case. So that really, like, was the step to getting government to listen, because that costs us, like taxpayers, and they're looking at saving money. So like, you know, like the cost of operating a shunt registry compared to one infection,
Yeah.
you save your money times 4 probably then.
Well, you make a good point. So if you could say reduce the number of shunt revisions in Australia by 5, that would fund the shunt registry. And they're the sort of data that we want to give to the government as well. And they're the sort of points, if you're going to write to your minister, we'd like you to make. But, you know, it's not a trendy thing to have. It doesn't affect a huge number of people, but it's really expensive. And the consequences to individual patients and their families can be catastrophic. I mean, if you've got a kid who gets a whole series of shunt infections, you can spend 2 months by the Cotton Children's Hospital.
Has the rate gone down with newborns
Things
since
are constant.
spina bifida has been finally, has spina bifida been slightly eradicated?
No.
So that's a slightly different topic, but with spina bifida,
I'm just wondering why you went straight to the children's hospital. You're saying the rates are high at certain kids.
no, the commonest hydrocephalus is predominantly in our community at the moment still something that is usually congenital or related to a childhood problem.
Yeah.
Over the next 30 years, we're probably going to see normal pressure hydrocephalus
Yes.
become more common. So spina bifida, the incidence is reducing in our community for a number of reasons. One is that people are using folate more frequently, and that information has gone out into the community, and most women who are planning a pregnancy start taking folate early, so that's helped. The second thing is antenatal screening has gone up enormously, so the quality of the ultrasounds if you have at 14 weeks are much better. And people are more willing these days to terminate a baby with spina bifida than they were 30 years ago. So, for example, when I was in Dallas, which is where I did my fellowship in the States, the antenatal screening wasn't as good, and it was a fairly religious community, and there was not a lot of terminations. And, I was repairing myelomeningocele 2 or 3 times a week. At Westmead Children's Hospital, which is far and away the biggest one in the state, I think we did about 6 last year. So it's definitely becoming less common. So I think hydrocephalus associated with spina bifida is definitely reducing, but the other forms are pretty consistent, like aqueduct stenosis and those sorts of things. And also, because the perinatologists, the neonatologists are much better, increasingly kids born at 24 weeks and 26 weeks surviving. A lot of those kids will have intraventricular hemorrhages, so that number is actually going up.
I mean, like you're saying, just on the rates of like surgery, adult versus child for hydrocephalus, what sort of ratio you reckon you've got there?
Again, to be honest,
Yeah.
that's difficult data to collect,
Yeah.
because at the children's hospital it's a fairly
Yeah, I know you'll see all the kids.
concentrated population. You get all the kids pretty much going through children's hospitals, but once you move into the adult hospital, I mean,
Yeah.
there's lots of private hospitals around where you can get your shunt device these days. So,
I mean, I know for me personally, I've got a shunt, and like what I usually try and do is pick a neurosurgeon who does child surgery, because they have a lot of experience with hydro.
yeah, and also, you have more experience, you understand the condition better, and you're a bit more empathetic.
Yeah.
You've looked after lots of kids with hydrocephalus, and you kind of get that it's also an adult problem.
As a general rule, just without a registry, neurosurgeons will be consulting with each other anyway, wouldn't they, if they discover a shunt that's working poorly, and that there's word spread around, and so
No, absolutely, but it's very difficult to kind of know unless you've got big numbers together. So with that hip that failed, it was by looking at thousands of hips to work out that this one was 3 or 4% worse than the other. So, I probably put in about 80 shunts a year, or revise 80 shunts a year roughly in my practice. And I tend to use predominantly one kind of shunt. I think we all use the one that we like the best, it's no better than any of the others. I
So
would-
they're actually more or less performing the same anyway.
Yeah, and you know, in our hospital, so Westmead's a public hospital, and we contract vendors. So on our shelf out the back in the operating theatre, you know, we've got a Strata valve, we've got an Orbis Sigma, and we've got a Sophie valve. You know, we don't have every single kind because, you know, these things run out of date and stuff like that. And if you don't use them, you throw them out or you donate them to India or Fiji. They've all got use-by dates on them. So they're expensive. You know, each one's worth somewhere between $1,000 and $3,000. And you need them on the shelf because you don't know that someone's not going to come in at midnight tonight who needs a shunt revision. So each unit would only have a couple of 7 or 8 different brands out there. And, you know, if we started to see one failing, you know, more frequently, yes, we would talk about it, but we wouldn't necessarily know that the one that we didn't have on the shelf was way better unless we had information like this.
If this registry takes off, and I hope it does,
Yeah.
I know it's seen by an adult neurosurgeon, of course, because I'm,
Yeah.
but how will he be able to get will he get a form sent to him and he'll say, Vicky, this is relevant to you, would you like to be a part of it? How does that work, or do I have to tell him about it?
I would suggest telling your surgeon, but the idea is that it's going to get rolled out into every hospital, so we'll make contact with all of the neurosurgeons.
So he's in Prince Alfred, for instance.
Yeah, so, you know, Prince Alfred would be one of the hospitals that we would hope would come on relatively early because, you know, it's got a strong association with the old children's hospital.
Yeah, because they're around the corner from each other. That's
Yeah.
where I used to work.
No, exactly. So we would hope that these forms would be sitting in the operating theatre there.
Yeah.
He would fill it out
Yeah.
and mail one. I didn't ask you about it at the time, but before your date is recorded, you'll hear from the Shunt Registry.
Okay, because touchwood so far, I've been healthy for 15 years, but what if tomorrow things were to go, you know?
No, exactly. And, you know, if your original shunt was...
Back in 2000?
Well,
latest
I
one?
mean, you know, I've looked after some people who had their shunts implanted in the 1970s
Yeah.
at the Royal Alexandra Hospital
Yeah,
for
that's me.
children. You can almost never get that stuff now. It's
No.
very difficult to get the
And
records.
Professor Ian Johnson, that was mine.
Question, you're also collecting information on ETVs.
Yes.
Is there really a known level of what percentage of ETVs are done, how successful they are, and problems with that at this point?
There are lots of really great studies in the literature about ETV, but not necessarily comparing them against shunts versus cholecystectomy and stuff like that. So,
Yeah. So,
you know, what we're hoping to do is look at what's happening across Australia and ultimately New Zealand as well. You know, if there is a huge number of ETVs being done in Victoria compared to New South Wales, maybe we need to look and say, well, maybe we should be doing more. Or similarly, you know, if they're having a very high ETV rate and they're all ending up with a shunt 12 months later, then probably the ETV isn't a smart way of dealing with that kind of problem. So that's why we're recording the etiology and all that sort of stuff. So, for example, if in the first line of that thing you're in the congenital box and you're in the aqueduct stenosis box, then logically an ETV is likely to work. If you're in the post-meningitis acquired hydrocephalus group, then probably an ETV won't work because we think that that kind of hydrocephalus is
we have
usually
the ETV
pretty
success scores anyway,
Yeah.
so I just wanted to probably improve on that.
Yeah, that's the sort of stuff we're hoping to collect.
Do they collect that on the UK registry, or is it only shunts?
I believe they collect that too. Well, I'm not 100% sure.
And Mark, will the UK registry data be accessible to the Australian Shunt Registry to do deeper analysis?
I think with time they would probably welcome us partnering with them and benchmarking our data against theirs. So, you know, we do that with a couple of other different things in neurosurgery. So, for example, we're now looking at collecting some data at Westmead. So this is separate from the NSA, and benchmarking that against the American Association data for certain things like readmission rates and stuff like that.
Right.
So there are all sorts of quality assurance programs out there, but that would be a good one down the track, is to look at the Australian data and benchmark it against the British. And hopefully we'll be better than them like we have been in the rugby.
Go on.
Any other questions? Okay. I think we should have learned a lot, and if we didn't learn a lot, we weren't listening. I think it's most important that we support this in any way we can. And Dr. Mark has given many suggestions what we can do. We will certainly follow that up in our newsletters and in our website and to do that. And in fact, I've been thinking for the last 5 minutes about a neurosurgeon in America. He's now standing for President, Ben Carson. Ben Carson was a major neurosurgeon in the States before he decided to go politician. And he's written quite a few books. And one of his books is Think Big. And I think we've got to think big. And we've got to do big. We're a little association, but we've got to try and hit this with a hard punch. Really support this. Mark, thank you so much. Very much.